Okay, welcome back, everyone, and thank you for allowing us a break. We'll move on to the next session. I will start with Dr. Sarah Oliver, who will be presenting updates to the Evidence to Recommendations Framework on COVID-19 vaccine booster doses in adults 50 years of age and older and in a population of immunocompromised individuals. So, Dr. Oliver, please go ahead.
Thank you so much, and good afternoon. Next slide. So today we'll discuss the data to inform the policy question for second boosters, specifically addressing the question, did the balance of benefits and risks warrant an update to COVID-19 vaccine policy, allowing adults ages 50 and over, and persons with moderate to severe immunocompromise, ages 12 and over, receive a second booster of an mRNA COVID-19 vaccine. Next slide. This slide shows the timeline of recommendations for COVID vaccine booster doses, starting in September when the initial doses of the Pfizer vaccine were recommended, then in October when the recommendations expanded to include both Mrna and Janssen, then the additional timing of recommendations up through January of 2022 when boosters were recommended for adolescents and the interval was shortened from 6 months to 5 months. Next slide. Then, following FDA's regulatory action, in late March, CDC updated its COVID-19 vaccination guidance to give some individuals the option to receive the second booster dose using an mRNA COVID-19 vaccine. These individuals include people ages 50 and over who received an initial COVID-19 booster dose at least 4 months ago. Again, persons 12 and over who are moderately to severely immunocompromised who got their previous dose at least 4 months ago. And people 18 and over who received both a primary dose and a booster dose of the J&J or Janssen vaccine at least 4 months ago. Next slide. We've seen this previously, and again, Dr. Hall will walk through this more in detail, but this slide now shows our current recommendations for the COVID vaccines by primary series product and by age. Next slide. Then this slide shows a timeline of recommendations for COVID-19 vaccine doses for the moderately to severely immunocompromised individuals that have been presented to ACIP. First in August, when ACIP reviewed data and made recommendations for the additional dose of an mRNA vaccine as a component of the 3-dose primary series. Then again, the additional expansion of the booster doses. Then in February, where a benefit-risk analysis was presented and the interval was shortened from 6 months to 5 months, and again in February when it went from 5 months to 3 months. Next slide. Then this slide shows the current recommendations for COVID vaccines by primary series product and age for persons who are moderate to severely immunocompromised. Next slide. Then this is the EtR framework we've used for booster doses previously, and this is what we'll walk through today. Next slide. So first for the public health problem. Next slide. This slide shows the trends in daily number of COVID-19 cases in the U.S. As of February 17th, there have been over 80 million cases of COVID-19 reported in the U.S., with our current 7-day average around 35,000 cases. Next slide. Then this graph is from a recent publication that shows the changing landscape of circulating variants by 2-week period during January of 2021 through January of 2022. During the first half of 2021, several variants circulated simultaneously as the Alpha variant in the teal color rose to predominance. Then the Delta variant in orange rose to predominance and almost completely displaced the other circulating lineages in late June, followed by the rapid rise of Omicron in the purple color in December of 2021. Next slide. Then this stacked bar graph shows the national weighted estimates of the variant proportions over time and the recent nowcast projections of the circulating SARS-CoV-2 lineages in the U.S. by week of specimen collection from CDC's COVID data tracker. The Omicron sublineages, depicted in different purple shades, have maintained predominance at 98 to 100% since late January. The BA.2 sublineage of Omicron, shown in lavender, was 74% as of the week ending April 2nd. Next slide. So then this slide just shows the daily trends in the number of COVID cases overlaying the variants. You can see the time period of Alpha, the Delta surge, and then what was notably the Omicron surge this winter. Next slide. These slides are trends in seroprevalence, or the estimated percentage of people in the US with the anti-nucleocapsid antibodies, indicating resolved or past infection with SARS-CoV-2 by age group. The results do not include the anti-spike antibodies from vaccination, and they don't estimate percentage of the population that may have sufficient antibodies to be protected from reinfection. The percentage of people with previous infection have increased over the course of the pandemic, with notable increases following the rise of the Delta and Omicron variants. But overall, lower seroprevalence has been noted in the older age groups, from 50 to 64 with 37%, and those 65 and over at 23% from recent estimates. Next slide. Then this figure shows weekly trends in the COVID-19 associated hospitalization rates by age group in the US from July 4th through April 9th of 2022. Throughout the pandemic, adults ages 50 to 64 and 65 and over have had higher hospitalization rates than the younger age groups. Next slide. Then taking a look at the trends in the daily number of COVID deaths in the US. Again, as of April 17th, there have been over 986,000 deaths due to COVID-19 reported in the US. Next slide. So transitioning to thinking about vaccination, we know that around 70% of the population 5 and over is fully vaccinated, and just under half of the population 12 and over has received a booster. Next slide. Then this slide shows the percentage of people vaccinated with at least a primary series on the left and a booster dose on the right by age group and date administered. 80% of those 50 to 64 have received a primary series, and 53% have received a booster dose. Then for the oldest population, those 75 and over, 86% have received a primary series and 70% are boosted. Next slide. Then another aspect of data shown on the CDC's COVID data tracker is rates of cases and deaths by vaccination status from 29 jurisdictions that routinely link surveillance and immunization data. Next slide. So we saw this slide from Dr. Daly earlier that shows the age-adjusted rates of COVID-19 cases on the left and deaths on the right by vaccination status and receipt of the booster dose. And again, the black line is those unvaccinated. Light blue is those who've vaccinated with a primary series only, and the darker blue as those who've received the primary series and a booster. People who were fully vaccinated with the booster dose had a much lower risk of testing positive and dying from COVID compared to people who were unvaccinated. This also highlights that the largest gap is between those who are unvaccinated and those who are fully vaccinated, but there's still an incremental benefit to also having received that first booster. This slide also shows that the gap by vaccination status increases at times when the incidence is the highest. Next slide. Then these are the same figures, but shown for specifically adults 50 to 64 years of age. You can see that there are similar trends to what we saw among all ages on the previous slide. Next slide. And then again, this is among adults 65 years of age and over. Next slide. Then the COVID network conducts population-based surveillance for lab-confirmed COVID-19 associated hospitalizations with a catchment area of over 250 acute care hospitals in 99 counties and 14 states, representing around 10% of the US population. The case definition is a residence in the surveillance area and a positive SARS-CoV-2 test within 14 days prior to or during the hospitalization. And then hospitalization rates by vaccination status can be monitored because COVIDNet also relies upon routine linkage to immunization information systems and the data are a representative sample of hospitalized cases. So next slide. Data from COVIDNet show that hospitalized patients that were fully vaccinated were more likely to have other underlying risk factors, including being older, being a long-term care facility resident, having other signs of long-term chronic or terminal illnesses, such as having a DNR, DNI, or CMO code associated with their chart, and having more underlying medical conditions compared with unvaccinated patients. Next slide. Then, as we heard from Dr. Link-Gallis previously, we have data from 3 doses in persons with moderate to severe immunocompromise, and more rapid waning is noted with this 3rd dose than we see with immunocompetent individuals. Although, again, note that in immunocompromised population, the 3rd dose is considered part of the primary series, and there's already a booster or a 4th dose recommended. Next slide. And again, this is the summary slide from Dr. Link-Gallis earlier, highlighting that booster receipt increases protection against all outcomes, and that booster dose VE has remained high among immunocompetent individuals 4 to 6 months after the dose, especially among the severe outcomes. Next slide. And again, highlighting the high 3-dose VE in the immunocompetent individuals, and then with waning noted in the 3-dose primary series in immunocompromised. Next slide. So in summary, for the public health problem, the current 7-day average for COVID-19 cases is about 4% of the peak that was seen during the Omicron surge. COVID-19 related hospitalization admissions and deaths are also continuing to decline from recent winter Omicron surge. COVID cases, hospitalizations, and deaths are 2 to 20 times higher in unvaccinated individuals in recent months compared to vaccinated individuals. And we know that the vaccine effectiveness for 3 doses, the primary series plus that booster, in immunocompetent older adults remains high, especially for more severe outcomes. Next slide. So next, moving to benefits and harms. Next slide. In an open-label, non-randomized study among healthcare workers in Israel, 4th doses were administered 4 months after participants received their 3rd dose of vaccine. After the 4th dose, both vaccines induced IgG antibodies to the SARS-CoV-2 receptor binding domain and increased the neutralizing antibody titers to points that were slightly higher than those achieved after the 3rd dose. Mild systemic and local reactogenicity was reported by a majority of recipients. Next slide. The same study was able to calculate early estimates of vaccine efficacy against infection of 4 versus 3 doses, so a relative VE, which was 30% for the 4th dose of Pfizer and 11% for the 4th dose of Mrna. Both estimates did have a 95% confidence interval that included no effect. Next slide. Then on January 2nd, Israel began administering a 4th dose of the Pfizer BioNTech COVID-19 vaccine to people 60 and over that had received a 3rd dose of their vaccine at least 4 months earlier. The 4th dose recipients were then followed from January 10th through March 2nd for confirmed infection and through February 18th for severe illness. Comparing persons in week 4 after their 4th dose to individuals that only had 3 doses of the vaccine, the 3-dose only recipients had higher rates of confirmed infection and severe illness. The 4th dose was estimated to prevent an additional 3 to 4 cases of severe disease per 100,000 person days compared to 3 doses. Next slide. So then, despite the 4th dose providing additional protection against infection, there was rapid waning of this additional protection that was seen beginning at week 5. The additional protection against severe illness did not yet show any waning at the end of the follow-up at week 6. However, note that the confidence intervals are quite wide. Next slide. Then another study among members of a large healthcare organization also evaluated vaccine effectiveness among persons 60 and over in Israel. The study included healthcare organization members that were eligible to receive the 4th dose that had not previously had a confirmed SARS-CoV-2 infection. The persons were matched to eligible people who had not yet received a fourth dose according to sets of potential confounders. Over 180,000 people were recruited and matched to controls after receiving dose 4 and followed for a median of 26 days. Next slide. Then comparing fourth dose to third dose from days 14 to 30 after receipt of the third dose, there was a relative VE of 72% for COVID-19 related hospitalization and 76% for death from COVID-19. Next slide. So then we undertook looking at the potential benefits around a fourth dose using the EPI data here in the US. Results were calculated per 1 million persons with primary series vaccination, primary series plus 1 booster, or primary series plus 2 boosters. The age group for the analysis was those 50 and over, and VE hospitalization estimates were 55% for the primary series, 88% for the primary series and 1 booster, and 95% for the primary series and 2 booster. Age-specific hospitalization rates from COVIDnet were used for the week ending February 26th, and calculations were done with a 120-day time horizon. Next slide. This figure shows the weekly hospitalization rates by vaccination status among persons 50 and over from COVIDnet. The weekly hospitalization rates per 100,000 per vaccinated persons is shown in black, those with primary series again in light blue, and with primary series plus booster in dark blue. You can see that by far the highest hospitalization rates are among unvaccinated, with hospitalization rates among those with primary series are slightly higher than among those who've received the primary series plus booster. And our overall hospitalization rates have been decreasing since January. Next slide. So this slide shows the estimated accrued benefits after mRNA COVID-19 vaccination among persons aged 50 years and over, with, again, benefits accruing over a 120-day time horizon. The top bar shows the COVID-19 hospitalizations prevented per million primary series completed. The next row shows the additional hospitalizations prevented per million booster doses given. And the bottom row shows additional hospitalizations prevented per additional 1 million second boosters given. As you can see, the most hospitalizations are prevented by the receipt of the primary series, with 3,700 hospitalizations prevented per 1 million primary series completed. Per 1 million booster doses, roughly 1,500 additional hospitalizations could be prevented, with 830 more prevented by a second booster dose. Next slide. So then this slide shows the same data described on the previous slide, but now in addition to the hospitalizations prevented, we also see ICU admissions prevented, depicted by the orange bars, and deaths prevented, depicted by the gray bars. We see the same pattern in previous slide, with the highest number of severe outcomes prevented by the receipt of the primary series, with smaller incremental gains from each booster dose. Next slide. So here we see the number needed to vaccinate to prevent 1 hospitalization over 4 months among persons aged 50 and over, with the blue bar showing the number needed to vaccinate with the primary series, the green bar showing the number of first boosters to prevent 1 hospitalization beyond the benefits already gained by the primary series, and finally the red bar showing the number needed to vaccinate with the second booster to prevent 1 hospitalization beyond the benefits already gained by the primary series and first booster. We can see that 135 primary series would be needed to prevent 1 hospitalization. Among persons who've already received their primary series, 674 would need to be vaccinated with the first booster to prevent 1 hospitalization. And among those who've already received their primary series and first booster, 1,205 would be needed to receive the second booster to prevent 1 hospitalization. So overall, to prevent a hospitalization, we would need to vaccinate 5 to 9 times as many persons with the booster doses compared to the primary series. Next slide. As always, there are some limitations for our benefit risk assessment. The model assumes static hospitalization rate over 120 days. As rates increase, anticipated benefits also increase. hospitalization rates among unvaccinated persons tend to have larger increases during times of increased transmission than those seen among the vaccinated persons. Therefore, the relative benefits of a primary series compared to booster will likely be larger during times of higher transmission. And the model does not account for prior infection. In addition, we're unable to calculate benefits for persons with immunocompromised specifically. However, we anticipate that the benefits would be greater and the risks would be smaller in this population. Next slide. So there are a few other considerations around the benefit-risk balance that we'll walk through here. First, for the risk of myocarditis and pericarditis. As we heard from our vaccine safety team earlier, there is a risk of myocarditis and pericarditis that's been identified after the COVID-19 vaccine booster doses in individuals 12 and over. There are some differences, though, noted by age group. Among those 12 to 39 years, the cases were mostly myocarditis or myopericarditis, with their onset less than 7 days after the first booster, and the risk is not as high as what's seen after the second dose in the primary series. Then among those ages 40 and over, the clinical picture is mostly pericarditis, and the small elevated risk is more spread out in the first 3 weeks after the booster. Then, as we heard earlier, the vaccine safety team will continue to evaluate severity and clinical course for the pericarditis cases in those individuals over 40. And as always, we will continue to closely review the COVID-19 vaccine booster dose safety with VAST. Next slide. And I wanted to briefly discuss a few theoretical concerns that have been raised as we think through boosters. First, the concept of immune tolerance. This is the concern that giving additional doses of COVID-19 vaccines would lead to lower antibody levels or a failure to restore antibody levels to what was seen after a previous dose or T-cell exhaustion. Currently, data do not suggest that this is a concern with COVID-19 vaccines at this time. I previously mentioned this study earlier, but from the study of healthcare providers that were given a fourth dose in Israel, the antibody levels, or the IgG binding antibodies after the fourth dose, were returned to similar levels seen shortly after a third dose. We know that the timing between doses is likely an important factor for development of immune tolerance as well. When attempting to induce immune tolerance, such as giving allergy shots, you must have frequent, so weekly or monthly exposure. And while there aren't data to suggest that this is occurring currently, we'll continue to closely monitor as we develop more data around additional doses of COVID vaccines. Next slide. Then the next theoretical concern I wanted to discuss is imprinting, which is the concern that the initial exposure to one virus strain primes the B cell memory and limits the development of memory B cells and neutralizing antibodies against new strains. Currently, the data suggest that a diverse response is obtained after priming with the current vaccines. So I'll walk through two studies at high level, but the citations are there below. On the left, you can see this is an animal study, that the majority of the memory B cell responses after a booster were cross-reactive to multiple variants, which is the dark gray in the pie chart, after boosting with both an ancestral vaccine, which is on top in red, or an Omicron-specific vaccine, which is the second pie chart in blue. Then on the right, this figure has a lot, and I know it's small, but I wanted to highlight and walk through kind of some overall conclusions. This is from a recently posted preprint of the Mrna vaccine, and this is a trial in humans. So overall, each color represents neutralizing antibodies to a different SARS-CoV-2 variant. The ancestral strain is in blue, beta in green, delta in orange, and Omicron in purple. Then for each variant, the first three data points on the left is a boost with the current ancestral Mrna vaccine. It's antibody titers pre-boost, day 29, and day 181 post-boost. Then the next three data points are a boost with a bivalent vaccine that includes the beta variant. So overall, what this data show is that after being primed with the ancestral SARS-CoV-2 containing vaccine, the vaccines that we've received, and then boost with either the current vaccine or a bivalent beta variant vaccine, either of those elicited neutralizing antibody titers to a variety of variants. So showing that we are still able to develop that diverse response even after priming with our current vaccines. Next slide. But as we think through the current benefit-risk balance for COVID vaccine doses overall and for the booster doses specifically, we'll walk through our known benefits. We know that there's the prevention of COVID hospitalizations, ICU, and death that we've discussed, as well as the other possible benefits, the prevention of post-COVID conditions and the prevention of COVID transmission. Then we balance this with the risk, the rare cases of vaccine-associated myocarditis, as well as the theoretical risks, such as immune tolerance and imprinting. Next slide. So in summary, data from Israel demonstrate an increased immune response after the 4th dose. There were higher rates of infection and severe illness seen in the 3-dose recipients compared to those who received 4 doses. We know that the greatest benefit from vaccination is achieved from receipt of the primary series and that first booster dose. But again, there is additional benefits that may be achieved through the receipt of a second booster dose. Then when reviewing the totality of the data, the known and possible benefits outweigh the risks, including our current understanding of the theoretical risks. However, there are individual factors that can influence the magnitude of the benefits for a second booster for each person. Then, as always, we will continue to closely monitor additional data to inform the theoretical risks as well. Next slide. So moving to values and acceptability. Next slide. A new survey by STAT and the Harris poll finds that 6 in 10 Americans have decided that they would receive another booster if it's recommended for them. Just under 1/4 of U.S. adults indicate that they would only receive a second booster shot if a new variant arises or if there's a surge in their area. And 18% have no plans to get a booster at all. This survey polled a little over 2,000 U.S. adults between March 25th and 27th. Next slide. Then they also showed that attitudes for receiving a second booster shot vary by age. 73% of baby boomers, those 57 and over, plan to get a booster if recommended at that time, compared to 48% of the Gen Zers between 18 and 24 years. Intent also varied by race and ethnicity. So among those polled, 54% of Black respondents, 43% of Hispanic individuals said they would get another booster, compared with 73% of Asian individuals and 65% of white respondents. Next slide. Then an ongoing survey by CDC and the University of Iowa and Rand Corporation was designed to assess vaccination intentions for the second booster in the next 4 months, specifically asking boosted U.S. adults age 50 and over, as well as understanding barriers towards receiving a second vaccine booster and understanding vaccine intentions for receiving another booster now and in the fall. Next slide. So looking at results for intentions for the second booster. Next slide. 82% of survey respondents said they definitely or probably would get a second booster dose in the next 4 months. Next slide. However, when specifically asked if they would get the currently available booster, this did decline to 68% of respondents. Next slide. Then 19% of respondents intending to get a second booster reported that they would wait for new boosters that protect against new variants. Next slide. Then this slide looks at the top reasons for not wanting to get a second booster. Belief related to another dose of the currently available vaccines not providing enough additional protection were underlying reasons, with 31% of respondents indicating that they have enough protection from their current doses. 24% are waiting for a new booster, and 18% felt that boosters weren't effective. Next slide. then we know that 86% of respondents definitely or probably would get a second booster if a new COVID vaccine protected against variants became available. Next slide. So now looking at the results of the vaccine intentions for receiving another COVID vaccine now and in the fall. Next slide. Overall, 70% of respondents said that they would get a COVID booster now and in the fall. Next slide. However, importantly, 10% of respondents said that they would get a COVID booster either now or in the fall, but not both. Next slide. Then this slide looks at the reasons given for getting boosted again now in the fall, the emergence of new variants, preventing spreads to others, and increased severity of cases were among the top reasons for wanting to get additional boosters. Next slide. And then as we continue to know that 40% of respondents indicated that recommendation from a healthcare provider was influential in their decision to receive another booster. Next slide. So in summary, a majority of adults that were eligible, 60 to 80%, state that they may get a second booster dose. However, we know that this varies by age and race and ethnicity. 20% of boosted adults 50 and over would prefer a vaccine that focused on new variants, and 10% state that they would get a booster now or in the fall, but not both. And a strong healthcare provider recommendation is influential in the decision to receive additional COVID vaccine doses. Next slide. Then for feasibility and implementation, next slide. These are the weekly trends and doses administered for those 50 and over. In blue for the weekly number of persons completing a primary series, and in orange for those 50 and over receiving a booster dose. Next slide. Then as we think through the eligible population, among persons who've been fully vaccinated, approximately 52% of people ages 50 to 64 and 67% of persons 65 and over have received a COVID-19 vaccine booster dose. At the time of authorization, there are around 30 million people who were eligible, so at least 4 months after their previous dose, which was about 10 million eligible individuals 50 to 64 and around 20 million eligible individuals 65 and over. Then we know that based on the timing of recommendations, persons with moderate to severe immunocompromised would not be eligible for the second booster, so that 5th total dose, until May 13th at the earliest. Next slide. We do know that the number of people reportedly getting vaccinated has nearly tripled since authorization of the second booster doses, to an average of almost 450,000 people per day ending the week of April 8th, compared to 160,000 people per day on average ending the week of March 29th. Then as of April 19th, approximately 1.1 million second booster doses have been given in adults 50 to 64, and 3.2 million second booster doses have been given in adults 65 and over. Next slide. So finally for equity, next slide. This slide shows booster dose vaccination trends, so the first booster, by race or ethnicity among fully vaccinated people in the US. So you can see at the top that individuals who identified as multiracial, Asian, or white persons have higher uptake of booster doses. Then there's a gap in uptake among some of communities of color with the AIAN, Black, or Hispanic or Latino populations. So while the gaps in race and ethnicity for vaccine uptake were closed for our primary series, we know that the disparities still remain with uptake for our booster doses. Next slide. Then I'm going to highlight that the next 2 slides, ACIP's actually seen before when we were discussing prioritization for the initial doses of COVID vaccines. This first column here shows the race and ethnicity breakdown for the overall population, and then on the right for the population 65 and over. Again, as ACIP has discussed previously, communities of color are underrepresented in the population that's 65 and over. Next slide. And again, ACIP saw these data in late 2020, but communities of color are overrepresented when you evaluate the prevalence of many underlying medical conditions. Next slide. Then this slide uses our COVIDnet data and shows COVID-associated hospitalizations among adults 50 and over by race and ethnicity and vaccine status. Those 50 to 64 are on top and 65 and over on the bottom. You can see that among those hospitalized with a primary series and booster, again, the population of focus for today's discussion, the white population is overrepresented in the 65 and over population for COVID-associated hospitalizations as well. Next slide. So in summary for equity, racial and ethnic minority groups are underrepresented in the population 65 and over, both overall and among COVID-associated hospitalization. While COVID-associated hospitalizations among adults ages 50 to 64 are more consistent with the underlying population. We know that underlying medical conditions are more prevalent in racial and ethnic minority groups as well. And a second booster recommendation for adults 50 and over may prevent COVID among persons from racial and ethnic minority groups, as well as from persons with underlying medical conditions. Next slide. So in summary, next slide. The top priority remains vaccination of unvaccinated individuals. Across all age and sex groups, the benefits are the largest for the receipt of this primary series. In addition, there are additional benefits to receiving that first COVID vaccine booster dose. This figure is the same that we've shown previously for the rates of death by vaccination status that you've seen before. The current policy question is focused on the population that has already received a primary series and a booster dose. So again, that bottom blue line. Just noting that this is the population with the lowest rates of severe disease currently. So while improving outcomes in this population is still important, we need to acknowledge that receiving the primary series and that first booster are very important in preventing COVID-associated disease, hospitalizations, and death. Next slide. Again, we've also seen this slide before, but overall, the goal of the COVID vaccine program currently is to prevent severe disease. There are important secondary goals as well: maintaining workforce and healthcare capacity, reducing infection rates and the risk of transmission, improved mental health with more social interactions, and the prevention of post-COVID conditions. Next slide. Then we know from what we've heard today, COVID-19 vaccines continue to offer high levels of protection against severe disease, especially for individuals who've received a booster dose. Vaccines are a critical aspect of protection against severe COVID-19. However, they're not the only tool in the toolbox we have these days. Monoclonal antibodies and antivirals are also essential. Continued research into vaccines that may have prolonged protection against SARS-CoV-2 infection, such as the potential for having a mucosal vaccine in the future, is also important. Next slide. So I'll walk through the workgroup interpretation for the two main focused populations for these booster discussions. First, for adults 50 years of age and over. The risk of COVID-19 increases with age, so a second booster, or this fourth total dose, for older adults can help ensure that those at risk are protected from severe disease. We know that the current VE shows limited waning for immunocompetent adults after a third dose. And we're in a setting with lower COVID-19 case counts and hospitalizations currently. And we do need to acknowledge that we may have recommendations for additional COVID-19 vaccines in the future. However, overall, when reviewing the totality of the data, the workgroup supported the recommendation that adults ages 50 and over may receive a second COVID-19 vaccine booster dose. Next slide. Then for immunocompromised individuals 12 years of age and over. Again, noting that the earliest eligibility for the second booster or fifth dose based on our timing of our recommendations would be mid-May. The currently available VE data is from the third dose in the primary series that does show waning. There's no VE data that's currently available for the recommended fourth total dose or first booster. We do have lower COVID-19 case counts and hospitalization rates currently. However, acknowledging that immunocompromised individuals likely remain at higher risk for severe outcomes. We know that there are immunocompromised individuals who have not received all recommended doses currently. So continuing to emphasize that it is important that these immunocompromised individuals receive all doses of the primary series, including those additional doses and that first booster dose. However, again, overall, when reviewing the totality of the data, the workgroup supported the recommendation that immunocompromised individuals ages 12 and over may receive a second COVID-19 vaccine booster dose. Next slide. So overall, the current recommendations that individuals may receive this COVID-19 vaccine second booster really reflect the current conditions in the pandemic. We have wide availability of COVID vaccines, high protection against severe disease from the primary series and that first booster, low rates of COVID cases and hospitalization, as well as use of antivirals and monoclonal antibodies. Overall, this is incredibly encouraging information, and we'll continue to closely monitor, but even as we've seen slight increases in cases for BA2 in recent days, we've not yet seen increases in hospitalizations or deaths. Then, as the second booster is already authorized and available, we can rapidly adjust recommendations if the COVID-19 epi changes in the future. The current recommendations allow for flexibility, giving patients and providers access to this vaccine dose and the ability to decide based on individual factors and timing. However, I know that as public health providers and practitioners, we're all being asked to help people decide what those individual factors and settings are. So for that, I'm going to turn to Dr. Hall, where she can walk through what we're initially proposing as considerations for these booster doses. And then we look forward to your input on these as well. Dr. Hall, next slide. Oh no. Okay. Hold on one second. We'll just need to bring up her slides. Hold on.
As you're pulling up the slides, Dr. Oliver, may we take one or two questions that are related to your presentation, and then we can open it up, or would you prefer to wait until after the clinical consideration?
I guess if they're clarifying questions on the data, I'm happy to take them now. If they're questions around the considerations, I would much rather wait for Dr. Hall's presentations, but I'm happy to do any clarifying questions for the data.
Noted, thank you. So clarifying questions only, Dr. Cotton.
On slide 66, you talked about who got a second booster, and it's a tremendous number of people who have had a second booster. I was wondering, with respect to equity, if you could tell us any type of racial breakdown of who's actually had a second dose. I'm a little concerned about the may get another booster, and I'm wondering who's actually getting them. Thank you.
Yeah, thanks, Dr. Cotton. We look forward to bringing you that data in the future. So we're, I think, kind of working on getting that data from the data tracker. So I don't have that available right now, but we'll look forward to bringing you that update as soon as it's available.
Thank you.
Lata?
Thank you, and thank you, Dr. Oliver. Clarification related to slides 36 and 37, where you're talking about primary series and 2 booster doses with a vaccine efficacy of 95%. Can you talk a little bit about what that means? And could it be because a lot of those second doses were being given during a time when Omicron was rapidly decreasing?
So for that, I'm going to pass it to Dr. Wallace, who's the stellar head of the data team on our team and who did the benefit risk analysis.
Hi, thanks for the question. So the VE that we got for the primary series and 2 booster doses was based off of the relative VE that just came out of Israel. I think it was, I think Dagan was the corresponding author that showed they had a relative VE from dose 3 to dose 4 of 72%. And so we back calculated that into an overall VE of roughly 95%. Does that answer the question?
Yes, thank you.
Thank you. Dr. Duchin and Dr. Feihofer, is it okay? Well, let me just clarify. If you have a quick question, please go ahead and ask, clarifying only, and I'd like to move on to Dr. Hall's presentation next. So Dr. Duchin.
Okay, thank you. I just wanted to clarify the summary slides characterizing the rate of COVID cases as low, which I agree is true compared to the recent Omicron surge. But if you look at the CDC community transmission rate map, much of the country is in high substantial or moderate and only a minority in low transmission. So if there's a chance to talk more about the implications of the cases and the potential complication of post-COVID conditions in making this decision, that would be helpful.
Thanks, Dr. Duchin. So first of all, absolutely, we still want to acknowledge, we have seen some increases. We went from, I think, around 25 to 28,000 cases this with the 7-day moving average to increasing of 35-ish thousand in the recent weeks. And there could obviously be some issues with some of the home antigen tests where we're not getting reports on every single COVID, positive COVID case. We watch that very closely with the COVID hospitalization, which definitely would have a broader capture and less of the testing concerns. And those have continued to decline. So we'll obviously continue to monitor, but I think we are still seeing continued decline as we look at not the COVID hospitalizations as well. Then I am not the expert on our community levels, but I do know that the 94% of the country is currently classified as a low community level in the green map. So as the community levels are assessed, the majority of the vast majority, the 94% of the country is still green. Thanks.
Thank you. And thank you, Dr. Fiho, for any additional questions we'll capture after. And of course, Dr. Oliver's presentation will be open for questions after Dr. Hall finishes her presentation. So please go ahead, Dr. Hall.
Thank you. So I'll be discussing CDC's clinical guidance for second booster doses. Next slide, please. So as has already been covered, the interim clinical considerations provides guidance that some populations may receive a second booster dose using an mRNA COVID-19 vaccine at least 4 months after the first booster dose. This includes 3 groups: people ages 50 years and older, people ages 12 years and older who are moderately or severely immunocompromised, and people ages 18 years and older who received Janssen as both primary and booster doses. Next slide, please. The second booster dose should be an mRNA COVID-19 vaccine, so Pfizer-BioNTech or Mrna. Janssen COVID-19 vaccine is not authorized for use as a second booster dose. Booster doses may be heterologous. It does not matter what FDA authorized or approved COVID-19 vaccine was received for the primary series or the first booster dose. However, of course, eligible people ages 12 to 17 years can only receive Pfizer-BioNTech COVID-19 vaccine. The dosage is the same as the first booster dose. So for Pfizer, this would be 0.3 milliliters or 30 micrograms of the gray or purple cap formulation. And for Mrna, this would be 0.25 milliliters or 50 micrograms of the red cap formulation. Next slide. So to reinforce what you've already heard, 2 of the 3 groups I mentioned are authorized under EUA, people ages 50 years and older, and people ages 12 years and older who are moderately or severely immunocompromised. The 3rd group is allowed through emergency use instructions or EUI, and that is people ages 18 years and older who receive 2 doses of Janssen. Regardless of the regulatory mechanism, a second booster may be given to a person from any of these 3 groups. Next slide. EUI materials, including fact sheets for healthcare providers and fact sheets for recipients and caregivers, can be found on the website listed on this slide. Next slide. The second booster dose does not change the definition of up-to-date. Being up-to-date means a person has received all recommended doses in their primary series and a booster dose when eligible. Receipt of a second booster dose is not necessary to be considered up-to-date at this time. Next slide. So with the new second booster recommendation, this slide summarizes the total doses by primary series product and age for people who are not moderately or severely immunocompromised. The left side of this table lists the primary series product and age group. The dark blue circles represent doses for which everyone in the age group should receive the dose. The lighter blue circle represents doses for which some people in the group may receive a dose. Next slide. So starting at the top, children 5 through 11 years who can only receive Pfizer should receive a total of 2 doses. Next slide. People who choose an mRNA COVID-19 vaccine primary series, Pfizer for people 12 years and older and Mrna for people 18 years and older, should receive a total of 3 doses. Some of the people in this group, those 50 years and older, may receive a 4th dose. Next slide. Finally, those who choose to receive a Janssen primary series should receive a total of 2 doses. Some people in this group, those 50 years and older, or those who have received 2 Janssen doses, may receive a 3rd dose. Next slide. This slide shows a summary of the recommendations for people who are moderately or severely immunocompromised by primary series product and age. Next slide. So again, starting at the top, children 5 through 11 years of age who are moderately or severely immunocompromised and can only receive Pfizer should receive a total of 3 doses. Next slide. Those who choose an mRNA COVID-19 vaccine should receive a total of 4 doses. They may also receive a 5th dose. Next slide. Those who choose Janssen for their primary series should receive a total of 3 doses. They may also receive a total of 4 doses. Next slide, please. So to help providers and eligible patients have a conversation and decide if the second booster dose is right for them as soon as possible or whether they might wait to receive the second booster dose, we plan to add considerations to our clinical guidance for those eligible groups. So for those who may consider getting the second booster dose sooner, this would potentially include people with certain underlying medical conditions that increase the risk of severe COVID-19 illness, and that would include those who are moderately or severely immunocompromised. Providers caring for patients who are moderately or severely immunocompromised may take into consideration factors such as the patient's degree of immunosuppression, as well as timing issues, such as initiation or resumption of immunosuppressive therapies. Another consideration would be people who live with someone who is immunocompromised at increased risk for severe disease or who cannot be vaccinated due to age or contraindication. People at increased risk of exposure to SARS-CoV-2, such as through occupation, institutional, or other activities. And finally, people living or working in an area where the COVID-19 community level is medium or high. This would include people who first become eligible when the COVID-19 community level is low, but it subsequently increases. Next slide. So on the other hand, eligible people who might consider waiting to receive a second dose could include people with recent SARS-CoV-2 infection within the past 3 months, and people who may be hesitant about getting another recommended booster dose in the future, as a booster dose may be more important in the fall or if a variant-specific vaccine is needed. Next slide. CDC will be creating educational material for providers and the public to facilitate a conversation around the second booster dose based on individual circumstances. Next slide. Finally, I would just like to acknowledge the people that put together the clinical guidance and the educational materials. Next slide. So can we go back now to my presentation? And in just a moment, I'll hand it back to Dr. Oliver. Oh, sorry. Sorry, Dr. Lee.
No worries. If it's all right with Dr. Oliver and you, I'd like to open up these series of presentations for questions. And I see Ms. McNally has her hand raised.
I have two questions, specifically regarding the antivirals or the monoclonal antibody therapies. Is there any indication that they're not as effective against the BA2 variant? And the second question I have is, what guidance are these providers going to give to people who suspect they may have had COVID-19 but are not positive in recent months? Thank you.
Dr. Thornburg, are you on? Okay. Dr. Scobie, do you want to comment potentially on anything on monoclonal antibodies or the current variants?
I think it would be better for the lab to comment, but there are differences in BA2 versus Omicron, the parental Omicron.
Yeah, I don't see Dr. Thornburg on right now, so we can work on making sure she is available to answer questions. But Dr. Scobie, if you wanted to, you're right. There are, and I don't just have off the top of my head the exact numbers. But Heather, if you have any of those, otherwise we'll work on getting that for you, Dr. McNally.
Okay, and then I'm sorry, did you respond to the first part of her question? I apologize if you already did.
Thanks. It was the second part about the antivirals.
The antivirals. Okay, it sounds like Dr. Oliver will return to that question, and I'm recognizing you have a few more slides you'd like to go through, and I see a series of hands raised. So let's come back to Ms. McNally's question and go through the other questions.
Dr. Lee, so sorry to interrupt. Could I have someone provide information regarding the guidance for people who suspect they may have had COVID-19 but didn't have a positive PCR or rapid test, how they should proceed with the booster recommendation? Thank you.
Yes, I'm going to actually ask if we park that question for a moment. Let's go back to Dr. Oliver, and then I actually want that question to be discussed, but I think it'll be really helpful for all of us. Dr. Oliver, we're still working on your slides going up.
Sorry, we're having a little issue getting the slides back up. 1 second. There we go. Thanks. Just trying to kind of pull it back that in summary, not only we've heard considerations around what was needed for we've heard a considerable amount of information around what is needed for second booster doses today. In addition, additional booster doses of COVID vaccines are also potentially going to be needed in the future. But we need to consider, we'll talk about, okay, give me just a second. Apologies, there's a lot going on. We know that it is important to optimize vaccine recommendations based on the current conditions while maintaining flexibility to update our recommendation as needed if the epidemiology changes. Next slide. So then I think this is getting to just opening up more formally to what Dr. Lee was saying. But what we would like to hear from ACIP is what are the factors that would influence the benefit risk discussion for patients and providers regarding second booster doses of COVID-19 vaccines. Thanks.
Okay, thanks, Dr. Oliver. So I'd like to get back to Ms. McNally's question around infection. Ms. McNally, could you please restate the question one more time?
Sure. Sorry, is it the guidance for the people?
Yes, thank you.
Okay. So I'm just curious as to what guidance these healthcare providers would be giving to people who suspect they may have had COVID-19 but are not positive that they had it.
So thus far, our discussion around sort of potentially delaying a booster dose by, as that slide had mentioned, 3 months was from symptom onset or a positive test. So they could also take it from symptom onset if they did not have
a viral test. But if you have suggestions as well, we would love to hear those thoughts, because one of the goals is to get your opinions on these considerations.
Thank you. And let us know when, if you have somebody else who can comment on the other question from Ms. McNally. We'll move on to Dr. Brooks.
Yes. Can you go back to slide 33, I believe it was? I hope that's okay after having such a chat. Yeah. So yeah, this is weak. So this is this the Israeli data? But this is showing a drop off, a significant drop off over a relatively short period of time, and vaccine effectiveness. Is that correct?
The short drop-off for confirmed infection, that is correct. You can see that the protection against severe illness, while the confidence intervals get wider as we go over time, did appear to kind of level out, and Israel wasn't seeing waning, but there was rapid waning of the additional protection against infection.
Okay, so again, back to what was on 82, I think the fact that, now protected well against severe disease, and there was some data that showed it protected against hospitalization, but I guess I just have a concern at the length of, if you will, effectiveness of this booster dose would be a major consideration for me in terms of determining how I would utilize a second booster. So I guess I want to confirm that we're seeing that there is a significant drop-off in effectiveness in a relatively short period of time.
Yeah, so I think we've continued, as we've seen with the primary series, the first booster, and then now the data from Israel with the second booster, that protection against infection is time limited. So we tend to see a decently fast drop off regardless of which dose it is for infection. We have seen that the protection against severe disease across the board is longer and more sustained. I will note that Israel also did say that they actually had not seen much waning for severe infection with their third dose. They just found some incremental benefit with the fourth. So the protection against severe disease is more durable, and we're not seeing that waning. But the protection against confirmed infection for all of the doses with the more recent variants has been very time limited.
All right, thank you.
Dr. Brooks, this is Amanda. Hi. I just wanted to add to what Dr. Oliver said. I think the final presentation of the day is going to be talking about sort of the future state. And I think what you're raising is the clear sort of, we're getting smaller incremental benefits with each additional dose from these vaccines, as you are pointing out. So I think we'll have some conversations and get some input from you guys about that at the end of the day.
All right, thank you.
Thank you. Dr. Lair.
Thank you for this presentation. To answer your question on slide 82, factors that would influence me would be similar to what Dr. Brooks just said, the duration of protection against severe illness. You pretty clearly said that as the rates of disease go up, there seems to be more benefits from the boosters. I think it's also true that as the risk level goes up, the people who have a higher risk are going to get more benefits from the vaccines, and those kinds of things are going to be useful. I'd also echo what Dr. Combs just mentioned, that concept of diminishing returns and getting your bang for your buck is something that's also important to me when I'm making these decisions. Thank you.
Thank you. Dr. Sanchez.
Thank you. And, very nice, informative presentations. Just a comment first. So up to date now includes a booster in addition to the primary series. I mean, that's, the so-called up to date. So I believe that's the change, because before it was just primary series. But so now we're considering only those who've been so essentially everyone who it's really the booster dose in addition to the primary series being those who are up to date. So that's the current recommendation, which I'm fine with that, but I believe it's a change in the naming of it.
So it may be a little. Oh, sorry. I just wanted to clarify. It may be a little confusing because we've had two different definitions. There's fully vaccinated, which is the completion 2 weeks after the completion of the primary series. But up to date, that has always been primary series plus a booster dose, but would not include the second booster.
Okay, so maybe I was thinking more of the fully vaccinated. So fully vaccinated to CDC is still just the primary series?
Yeah, the fully vaccinated is still just 2 weeks after completion of the primary series.
Thank you. And then other factors, with the rapid decline with the durability of the second booster, I'd like to do those individuals who've had first of all, I think we need to see how much the virus is circulating to see how much protection they're going to be getting, and certainly what other risk factors are being, there's going to be exposure factors as well as age and host immune type issues. But on top of that, I just wonder if someone who's recently had COVID infection really needs a second booster, considering they've recovered. I mean, obviously, if they've recovered from a recent one, do they really need a second booster 3 months later when we're at this point? So I think some explanation and some further clarification about the need for a second booster in those who've already had COVID, because it should be commented on, because natural infection plus booster seems to have the best antibody production.
Dr. Oliver, I don't know if you want to take this, or I know Dr. Thornburg is now on. I wonder if she could comment as well about this, as well as the other questions that were raised.
Yeah, hi, sorry. Yeah, this is Dr. Thornburg. Okay, so I think the question, Sarah had sent me a question that was asked about antivirals and monoclonal antibodies, specifically about BA2, and there's no loss. We know that there's no loss in activity in the oral antivirals against BA2 variants. There is loss of activity for some of the monoclonals against BA2. I think citribimab. There is a reduction in neutralization against BA2, and I think that was maybe one of the contributing factors to the change in the EUA. I don't know if there's any further loss or change in the activity against some of the newer subvariants that are coming up, like BA.12.2. And so I think we'll hear more about those in the next coming week or two from our therapeutic colleagues. And I'm sorry, was there follow-up questions to that I missed?
There are two questions that are related on the table regarding what to advise individuals who have had recent infection. Dr. Hall did present a suggested 3-month delay in second booster doses. So I think the questions are related to, what should the provider sort of advise their patient with someone with a recent infection, and then more specifically, Dr. Sanchez, if I'm paraphrasing, is asking, is a second booster necessary if functionally they had an infection and they were also previously fully vaccinated and boosted, i.e. up to date?
Gotcha. So if it's a recent infection, I think that we have pretty good data that there's not a lot of reinfection
like within Omicron. So Omicron is different enough from the other earlier variants that, I think we could see pretty rapid succession reinfection. Say if someone got Delta in early November, we were definitely seeing reinfections in December, January. I don't think that's the case with Omicrons, and there is, at least domestically, everything that's circulating are versions of Omicron. So if someone has had a recent infection, it is probably Omicron, and they are probably, especially if they've been vaccinated and recently infected, have good protection against currently circulating viruses. If it's a more distant infection, so maybe something Delta, say, before December, that's probably not the case. And they wouldn't have protection against Omicron. And then about, vaccination boosters, just loss of activity, I think that is an unfortunate byproduct of the viruses that we're seeing circulating right now. Even if you have really good boost and even some longevity to the ancestral strain, so to vaccine strain, any decay of antibodies that we're seeing against vaccine strain, it's not surprising that it's sort of exacerbated by Omicron, because there's it's not a loss of neutralization, but a reduction in neutralization against Omicron. So, 35-fold. So instead of starting with 100, I'll just make up a number. Say if you're starting with 100, instead you're not really starting with 100, you're starting with 35. So you hit that 0 unprotected threshold much quicker than if it were something circulating that was closer to vaccine strain.
Thank you, Dr. Thornburg. That was incredibly helpful. Dr. Oliver, are there any other comments related to that topic?
Hi, this is Sarah Meyer. I just wanted to chime in at the end of that conversation. We do address vaccination in previously infected people in our clinical guidance. We do continue to recommend that people who have been previously infected do get COVID-19 vaccination, because there are data that there is additional protection conferred for these people. As it relates to the second booster dose, as Dr. Hall mentioned, in our clinical considerations, we are proposing, as people think through, should they get their second booster now, or can they wait a little bit? Recent infection within the last 3 months is kind of one of those factors that we are suggesting, people could hold off on their second booster if they want to. But we, in general, do continue to recommend that people who are previously infected do get vaccinated.
Thank you. Dr. Bell.
Thank you, and thanks for these great presentations. To answer this question from my perspective about factors and things to consider, one thing I'd like to sort of highlight is that I do think that these clinical considerations and the clinical guidance about this question is quite helpful. But as you've heard, there are lots of moving parts. It's not ideal that we're left in a situation where for now this really is around individual decision making, but as you've heard, I think at least the work group felt that there's just not enough compelling data to say, everyone, this is a recommendation. So in that situation, providers are really pivotal to advising patients. And if we are going to direct them to the clinical guidance and clinical considerations at CDC, that really needs to be nimble. And so that's sort of my message back, is that if that's going to be the central point for guidance, you've heard about more data about longevity of protection, more data in stratified age groups, the whole issue of diminishing returns. There's all of these moving parts, which is why we are still saying people can consider this. So it's really important for all of the pieces to be connected and lined up so that there is actually very nimble and quick updates for providers as as the situation changes.
Thank you, Dr. Bell. Dr. Daly.
Yeah, thanks so much. This is a comment, and I'm going to try to do something that's, I think, a little tricky, but I'll try my best, which is to say, how do we interpret declining vaccine effectiveness against infection and then relative to severe disease? So, interestingly, and sort of how does the public interpret that? Interestingly, I have, friends and family and colleagues who had gotten vaccinated and then got infected, and some of those individuals say, my COVID infection was very mild, and that's thanks to vaccination. So they interpret that as a perfectly fine scenario, and they're really glad that they were vaccinated because their disease was mild. And then I've heard from others who are vaccinated and then develop COVID and sort of say, oh, that shows that the vaccine's not working. And so I think, we all need to be clear that these vaccines are not going to prevent all infection, but in many circumstances, they may result in mild infection, and that should be interpreted sort of in that context. And then I think, as Dr. Oliver highlighted, the primary goal of the vaccination program is to prevent hospitalization and severe disease. And I'm not saying that infection is not important. It's very disruptive, and we've talked about post-acute COVID. So it is very important, but still the primary goal is prevention of severe disease. And so when I look at declining vaccine effectiveness against infection, one of the more important points for me is that then predicting declining vaccine effectiveness against these more severe outcomes, or is it not? And I would just highlight that at this point, the data on a fourth dose is quite limited, but I don't think that declining VE against infection is currently predicting or associated with declining VE against the more severe outcomes. But I think we're going to need to monitor it very closely. So that's my overall comment, and I'll stop there. Thanks so much.
Thanks, Dr. Daly. I'm going to jump in, and then I will ask our liaison members to weigh in. I just want to comment on this particular question. It's interesting because I certainly understand that our strategy is to prevent severe disease, hospitalization, and death with the currently available vaccines. But when I think about what would make me get a second booster dose, I actually would want to prevent infection. And I'm just trying to time when that prevention of infection would be optimal for me, given that we are at a May stage right now. So I don't think that it's only about severe disease. I do think that we need to actually continue investing in vaccine development towards a vaccine candidate that can really prevent infection. And I think that's where we're going to have significant benefit. I'll just throw in a couple of other things that I think we need to consider in the benefit risk discussion that we don't have sufficient data on, but I, again, think there needs to be further investment. One is PASC, or long haul COVID. We focus in on hospitalization and death and the acute illness. We are not thinking about the long-term consequences of COVID, and that can occur even in mildly symptomatic individuals. And the second is, we have certainly done this for flu and other vaccines, but I actually think that the missed work, missed school aspect is substantial. And potentially a reason that people, want to receive vaccines. The disparities are already there in terms of, the impact of infection on communities that may not always have that have challenges with access or challenges with healthcare coverage. So I do think that it's really important. We also know the pandemic impacts, job security and things like that. So infection is actually quite impactful on people's lives. And the disparities that exist will continue to worsen if we don't look ahead and target infection as an important thing for us to consider as a committee. I recognize we can't do that exactly today with the vaccines we have, but I think we need to do better. Dr. Talbot.
And to your point, Dr. Lee, I think it will be very difficult to prevent infection with the current vaccines that we have. And so I think our goal at this point with the vaccines that we have is to prevent severe disease. And we have to figure out how to use those current vaccines to prevent severe disease. And so I think we have to be very clear about what we can and cannot do with the vaccines. I think we need to be very clear about how much we gain by continuing to use this vaccine to prevent severe disease. So thanks.
Thank you. Ms. Mata?
Thank you. Similar comments to what you said, Dr. Lee, that as long as we have infection, even despite vaccination, we're going to be seeing constant mutation of this virus. And at what point do we, it feels inevitable that this is going to be ongoing. And at the current level of severity that this disease can cause, both acute and long-term, I agree we need to be thinking about how to make a better vaccine. And I hope that we're not going to settle to keep making recommendations or changing the guidance for, okay, after 3 months, people may get a third booster or fourth booster. I feel like, again, we need to continue to be clear on where this is headed. And I appreciate the fact that with Omicron and the amount of circulating disease, it was impacting those individuals who are at higher risk for severe disease despite vaccination, and that we do need to keep doing something and be nimble with those recommendations. But I also think that we need to use our expertise to advocate for something that's better, something that can really resolve the ill effects of disease, whether it's mild or severe. Thank you.
Thank you. We'll go to Dr. Cotton and then Dr. Schechter after that.
Thank you for these excellent presentations. At this point, as a clinician, I am really pleased that we have so many vaccine options and that we have the capacity to provide especially a second booster dose for people who are moderate to severely immunocompromised, which I think allows for significant clinical flexibility. And that plus the monoclonal antibodies that can be used for either pre-exposure prevention or for treatment, as well as the oral COVID therapies. It's really a whole new era for me treating vulnerable patients. I was wondering if anyone could comment with this second booster dose as far as if there will be recommendations for use of Evusheld and this booster dose, or will there be further information or guidelines on that? I know that Evusheld is something that's usually covered by the FDA, and so far I don't think there have been CDC recommendations, but there are always a lot of questions. My understanding is that the use of Evusheld does not interfere with the response to vaccination, but nonetheless, there's at least a recommendation to separate them by 2 weeks. I don't know if anybody on the call could comment on that.
Hi, this is Sarah Meyer. So I think just to kind of reiterate what our current guidance is for people who are receiving Evusheld, we do not have any sort of interval after which you receive Evusheld to receive vaccination, but per the product EUA for Evusheld, you need to wait 2 weeks after vaccination to receive Evusheld. So I know that's a little bit confusing. But in terms of other recommendations around use of Evusheld, the NIH treatment guidelines is kind of the place where those recommendations are housed. We, in our kind of vaccine guidance, we don't have any other specific recommendations around Evusheld, but we do, encourage, for the immunocompromised population and their providers to kind of take advantage of every tool available to help protect them. So we have our, vaccine guidance for them, and we also link out to the Evusheld guidance, and we do have some web pages and materials either already posted or under development that we hope will make information a little bit more centralized for that population, so that when they do go to seek information on our website, they are aware of both the vaccine recommendations for them as well as the recommendations around Evishield. I hope that answered your question, but please let me know if you had something else in mind.
Thank you very much. That's excellent. I think there's a confusion from prior recommendations regarding monoclonal antibodies and waiting a certain amount of time to get vaccine, but now that has largely gone away. So people are still using some of the residual recommendations, I think, is part of the problem. But otherwise, thank you very much for your response.
Thank you. Dr. Schechter, thank you for your patience. Please go ahead.
Thank you, Dr. Lee. Two questions or comments related to Dr. Hall's presentation. The first is thinking about the immunocompromised patients and the earlier discussion about risks at 50 versus 100 micrograms of Mrna vaccine. I'm just wondering if we'll get any information about the adequacy of or the room for improvement in a 50 microgram dose of Mrna for immunocompromised patients, or whether there'll be any additional information about whether a higher dose is of any benefit in the vulnerable group. Question two is, or point two around, I think slide 16 in Dr. Hall's presentation in terms of framing it in terms of waiting until the fall and the assumption that the next surge would be in the fall. And I just wondering about the possibility of another emergence like Omicron before the fall, and trying to think about how quickly we can pivot for a rapid surge and how much lead time is feasible, and so when to wait and when to intervene. And related to that, being nimble, whether how the modest waning in effectiveness against severe outcomes seen in a couple of studies early in the morning, how that compares with the marginal benefits of seen in the Israeli studies of the fourth dose. How much time are we be buying in terms of trying to optimize that second booster dose? Thank you.
So starting with the first one, right now, I don't think we really have any data on the higher Mrna dose being used as a booster, but that's something we can certainly continue to follow up with the manufacturers on as to clinical testing of a higher dose in this population. For the second question, that's a little more programmatic and out of my scope. So I'm going to pass it over to Dr. Oliver.
Thanks, Dr. Schechter. I'll answer it in two parts, which part of it is some of the thinking about the fall and the winter and the future. I have a little bit more data and some discussion in kind of the next section of slides. So some of that potentially can be discussed then. But did want to think about something that I said in the conclusions, which is specifically as it relates to the second booster and how that could inform an individual's, decision with which to get that. Our ability to be nimble for that is incredibly high right now. So the dose is already authorized. It's already at the pharmacy, and it's already recommended. So if there was a note of increasing cases, and then back to kind of earlier what has been discussed, there's modeling that we'll continue to work with. I think there's wastewater surveillance. So it's not just our COVID case counts, but it's the variety of methods that CDC is looking at to ascertain cases, disease burden, transmission. But we could meet and ACIP could discuss, or CDC could update our clinical considerations incredibly quickly based on changes in epidemiology, especially as it relates to this second booster, as it is already authorized and recommended. Thanks.
Thank you. Ms. Stinchfield.
Thank you, Dr. Lee. Thank you, Sarah Oliver. Wonderful presentation, always helpful. A couple of clarifying questions quickly. One is on your slide about those who live in a household with someone who may not be age eligible. I just want to make sure I'm understanding that. So the scenario could be that there's parents of children 4 and under who are not themselves 50 years old, that they could be eligible for second booster. Am I understanding that right?
So for the second booster, they would still need to be age eligible within one of those 3 groups. The intention there was more living in a household with someone who cannot get the vaccine because they aren't age eligible. So if you had a very young child that could not get it, or a contraindication as well. So that was more of the intention with that one.
So a parent of a very young child who's not age eligible would themselves have to also have some high risk reasons for a second booster?
Yeah, so this is Dr. Oliver. Yes, so the authorization is for those who are moderate to severely immunocompromised 12 and over, or for 50 and over. So they would need to be, or they would need to be that, or have received 2 doses of a J&J vaccine previously. But if they also, in addition to either being 12 and over and immunocompromised or 50 or over, happens to be with somebody who is unvaccinated or under-vaccinated, that could be something that they could take into account. But singularly living with somebody who is not vaccinated, that alone is not an eligibility to get the second booster according to the authorization.
Okay, thank you for clarifying that. The way it was written, it didn't sound like that to me. So thanks for clarifying that. And then just 5 to 11, could you just make another comment about your overall sense of them not needing any boosters at this point in time? Is it our confidence in their response to their primary series? Can you just comment on that population? Thanks so much.
I'm sorry, can you repeat that question?
That 5 to 11 are not eligible for boosters at this point in time, and just commenting on our sense of their ability to protect themselves with just the primary series. Can you just talk a little bit more about that?
Oh, yes, sorry, I missed the end of that question. So I think we are aware that Pfizer has had a press release for their data on boosters in 5 through 11, and so we look forward to that data being submitted to FDA in the near future. And so hopefully we can have kind of a comprehensive discussion of the 5 through 11 program, including kind of safety and VE, as well as the need for boosters in that population in the near future. The work group's already kind of been reviewing that data, and so we look forward to having that publicly discussed at ACIP, hopefully in the near future.
Thank you.
Thank you for those questions. Dr. Hahn.
Yeah, hey, thank you so much. As a state public health epidemiologist, I'll say that we are really struggling right now between trying to encourage people to understand and consider boosters and trying to distribute Evusheld to our immune-compromised population. I want to thank Dr. Cotton for bringing this up, and I did on our work group, someone was able to send out her very lovely editorial on this subject. It is really important. I appreciate the work that is being done to make awareness more out there in different ways, but I really do think this should be addressed in ACIP discussion, as other things are, whether or not, first of all, encouraging people to be aware of Evusheld providers. We find a low awareness and interest right now among our providers, making sure they're aware of it, and also harmonizing that recommendation, just what was discussed about the intervals and so forth. I do think that should be part of any guidance about the second booster. Thank you.
Thank you for making those comments. They're really important. Dr. Lair.
One question for Dr. Oliver and one question for Dr. Hall. Dr. Oliver, you mentioned two theoretical considerations of immune tolerance and imprinting. I was wondering if you have any information about whether those have ever been actually identified in past vaccine examples.
Thank you for that broad question. So I'm happy to say that we have, been discussing doing some in-depth research in this previously. So potentially our best understanding of where we may be thinking about this with regards to COVID vaccines is our experience with influenza vaccines. And so I'm happy to give you kind of my current understanding and discussions I've had with our experts here, and then I'll see if others in the room want to comment as well here. But overall, it is very difficult with influenza to have and broadly to have definitive studies in this because there are so many other factors. So specifically with influenza, we know VE varies by year overall anyway, and can vary by strain. And so it's difficult, again, to have kind of a definitive study that's able to prove or disprove either imprinting or immune tolerance. I will say that our flu experts have reminded me that ACIP has discussed this currently, though, overall. And even if there are some concerns with having repeated doses of influenza vaccines potentially having an impact on VE, overall, the benefits of getting the annual vaccine still far outweigh that risk. And so that they continue to study and learn more about that topic, but they still continue to strongly encourage everyone to get their annual flu vaccine because the marginal impact that could be noted potentially from an issue with immune tolerance is still better than kind of not getting your flu vaccine at all, because you still continue to get considerable benefit from that. Okay, I was getting thumbs up from people in the room, so I think we're going to go with that. Thanks.
And for Dr. Hall, on slide 17, you have your education and communication templates. And on the left-hand side, you have clinical considerations, and the right side is thinking about getting it. At the bottom, in the green section, it says, separate the second booster dose from the previous dose by at least 3 months. But on the right-hand side, it says, make sure it's been at least 4 months since your last COVID booster. And I wasn't sure if I was missing something in one of those, if they're both accurate and I'm missing something, or if one of those is just a mistake. Thank you.
You're not missing anything. I appreciate you pointing that out, actually. That is an error. The second booster should be separated by from the first booster by 4 months, and the 3 months is incorrect. So thank you.
Thank you. And Dr. Daly, you'll get the last word.
Okay, yeah, thanks so much. This is going to come back to the comments you made, Dr. Lee, and that Dr. Talbot made. I think in this public meeting, it's really important for us to discuss the limitations of the current vaccine platform and sort of acknowledge those limitations. And I also think we need to distinguish, what are the limitations of boosters as a strategy compared to what are the limitations of this as a vaccine platform. However, for the listening public, I think I want to take one big step back and say, when we look at the burden of hospitalization from COVID and the burden of death from COVID, does that represent vaccine failure, or does that represent failure to vaccinate? And it seems that really, based on the data we have, is more a reflection of failure to vaccinate, meaning folks that are getting hospitalized and dying from COVID often are unvaccinated. There are some exceptions to that, individuals who are immunocompromised or at the extremes of age. But I think we need to sort of acknowledge that the current vaccination platform has averted hundreds of thousands, if not more, deaths. And so that is a benefit that we're really accruing from the current vaccination platform, while we can still have conversations about what we think the limitations of the current platform are and the use of boosters. Thank you.
Thank you, Dr. Daly. That was perfect. We will now take a break. Dr. Wharton, I'm going to suggest we take a 9-minute break. So we'll come back at, we'll take 10 minutes. We'll come back at 44 minutes after the hour, and we will convene for public comment. Thank you.